Good morning, everyone. This is Keshav. I'm one of the second year internal medicine residents at Memorial Healthcare System in South Florida. I'm excited to present this case today of a young patient with monomorphic SVT presenting as a convulsive syncope. A brief introduction into the pathophysiology, which is hypothesized to be likely related to global hypoperfusion to the cerebrum and cerebellum, resulting in syncope and convulsive movements. Another possible pathophysiology revolves around brainstem release phenomenon, where the lack of cortical inhibition causes patients to develop syncopal episodes with convulsive movements. So our patient was a 23-year-old male who worked as a landscaper and had a documented history of excessive energy drink use. He presented to the emergency department via EMS services after a syncopal episode followed by seizure-like tonic-clonic generalized movements requiring emergent and challenging intubation while being en route to the hospital. Initial vitals showed hemodynamic instability, fever. Initial labs showed leukocytosis, lactic acidosis, and an elevated hematocrit, likely suggesting volume depletion. Cultures were sent. Initial EKG revealed a monomorphic wide complex tachycardia, likely SVT, with RBBB morphology. Patient received IV amiodarone bolus with infusion, as well as magnesium bicarb pushes for his acidosis, as well as IV fluid resuscitation. EKG 6 hours afterwards revealed a normal sinus rhythm and a normal QTC. In the meanwhile, patient was also loaded with 4 grams of IV levetiracetam for suspected underlying seizures, as well as broad spectrum antibiotics due to concerns for aspiration pneumonia. Patient also required propofol and midazolam infusions, as well as addition of valproate to his anti-epileptic regimen due to persistent convulsive movements. He was transferred to the ICU for vasopressor support as well as continued sedation. Pan cultures remained negative. Imaging ruled out any intracranial abnormalities, leptomeningeal enhancement, or pulmonary embolism. Echocardiogram revealed a normal EF as well as no structural deficits or defects. LP revealed an elevated opening pressure of 32 centimeters H2O and protein of 137, but was otherwise unremarkable. Extensive serum and CSF workup ruled out any infective, autoimmune, or paraneoplastic etiology. Long-term EEG monitoring was negative for any seizure activity. Patient was extubated on day 3 of hospitalization and was discharged on a low dose of beta blocker. This case highlights the need for distinguishing convulsive syncope from a possible underlying seizure defect or seizure disorder. Important questions that arise in this case are: how can we be certain that this patient's seizure activity was not exactly seizures but entirely related to transient cerebral hypoperfusion? We have evidence on our side in terms of completely negative workup for anything remarkable except the EKG changes, which normalized after adequate treatment. In this case, the most common cause for our patient ending up having a monomorphic SVT with convulsive syncope was excessive caffeine intake as well as outdoor work causing volume depletion. There have been case series where vasovagal syncope has in turn resulted in convulsions. This case is extremely important because it can prevent incorrect and unnecessary treatment of similar patients with anti-epileptic drugs, many of which can have undesirable side effects. Thank you very much for your time.